Shot through the heart, and you're too late, darling. You give love a bad name.
We're doing a research project on bundle branch blockage, a condition in which there is a delay or obstruction along the pathway that electrical impulses travel on to make your heart beat. But before we start, we need to understand the heart and how it works. The heart is located in the mediastinum, which is the medial cavity of the thorax. It is flanked on both sides by the lungs and rests on the superior surface of the diaphragm. It also lies anterior to the vertebral column and posterior to the sternum. 2/3 of it lies to the left of the mid-sternal line. The heart is enclosed in the pericardium, a double-walled sac within the mediastinum. Between the parietal and visceral layers of the serous pericardium is the pericardial cavity, which contains serous fluid that lubricates the membranes. The inner layer begins with the visceral layer of the serous pericardium. Next is the myocardium, which is the muscular layer of the heart wall. Cardiac muscle cells, which receive and respond to action potentials by causing the heart to contract, are here, in addition to the cardiac skeleton, formed by dense connective tissue, which limits the spread of action potentials to only direct pathways. Finally, the innermost layer is the thin endothelial endocardium.
The general purpose of the heart is to pump oxygen-rich blood to the body tissues for metabolic usage through gas exchange, and also to pump oxygen-poor blood returning from the tissues to the heart and subsequently to the lungs, where the blood picks up more oxygen through gas exchange. Now let's look at how the heart pumps blood throughout the body. First, oxygen-poor blood comes back from the rest of the body and flows in through the superior and inferior vena cava into the right atria. The right atrium then pumps the blood into the right ventricle through the tricuspid valve. After that, the right ventricle pumps blood through the pulmonary valve to the pulmonary arteries, which lead to the lungs, where the blood becomes oxygenated. This oxygenated blood re-enters the left atrium through the pulmonary veins, where it is pumped through the mitral valve to the left ventricle. This left ventricle pumps the rest of the blood through the aortic valve to the aorta, which leads to the rest of the body. The blood is pumped by the atria and again by the ventricles due to an action potential rhythmically traveling through the heart as an impulse. This impulse is created by autorhythmic cells in the sinoatrial node, which are self-stimulating through potassium, calcium, and sodium channels. This is the start of atrial systole, or atrial contraction. Let's talk a bit more about these autorhythmic cells.
About 1% of cardiac fibers are autorhythmic, or pacemaker cells, which are special because they are part of the intrinsic conduction system and continuously depolarize due to an unstable resting potential continuously drifting towards threshold. There are 3 parts to the action potential created by these cells. The first part, the pacemaker potential, is a slow depolarization from negative 60 millivolts to negative 40 millivolts due to the opening of sodium and closing of potassium channels on the cell membrane. Once the cell hits negative 40 millivolts, the next section, depolarization, begins, in which calcium channels open and cause a fast depolarization to a charge just above 0 millivolts. Finally, repolarization occurs when the calcium channels close and potassium channels open, causing potassium to leave the cell and causing the membrane to become more negative. This continues until the potential reaches negative 60 millivolts, when the sodium channels open once again and the pacemaker potential part of the action potential begins, causing the cycle to repeat itself.
The impulse travels from the sinoatrial node to the atrioventricular node, where it pauses for 0.1 seconds as the ventricles fill with blood from the atria. This corresponds with the PR segment of an ECG, which we will discuss later. The impulse travels from the AV node to the AV bundle, also known as the bundle of His, which is the electrical connection between the atria and the ventricles. Then the impulse passes down the right and left bundle branches through the interventricular septum. At this point, atrial systole is ending. Finally, the impulse reaches the myocardial septal cells via the Purkinje fibers and causes ventricular contraction. Once the ventricles contract, it starts the beginning of ventricular systole and lasts until the action potential has passed.
So now we're going to look at a BBB on an electrocardiogram and compare a normal ECG with one with blockage. So we're going to talk about normal ECG lead 2 values first and explain what each of these intervals and segments mean. The P wave represents atrial depolarization and should last less than 0.12 seconds. Its P wave rate should correspond to a normal heart rate and should be 60 to 100 beats per minute. And its P amplitude should be less than 2.5 millimeters. This is the PR interval right here, which is the period from the start of atrial depolarization to the start of ventricular depolarization. A normal interval would be between 0.12 to 0.20 seconds. The QRX complex represents left and right ventricular depolarization and should be less than 0.10 seconds. This QT interval, which is the period of time in which electrical depolarization and repolarization of the ventricles occur. A normal interval lasts 0.42 seconds. The T wave is this positive deflection after the QRX complex and represents ventricular repolarization. From here, the beginning of the QRX complex to the apex, which is the top of the T wave, is called the absolute refractory period. The ST segment is the interval between ventricular depolarization and repolarization. Normally, there is no elevation or depression, so just a flat line. Now that we've gone over normal values for a normal ECG, let's look at a lead 1 ECG with BBB and compare the differences. These are general characteristics shared by both right bundle branch block and left bundle branch block. So first, as you see here, the QRX complex is prolonged and usually greater than 0.12 seconds due to the blockade. The morphology, which is the shape of the complex, becomes deformed in both right bundle branch blocks and left bundle branch blocks, and changes to that resembling bunny ears for the left bundle branch block. As you can see here, the T wave is abnormal in appearance because of alterations in the repolarization of the heart caused by altered depolarization conduction pathways. It can be taller than in normal ECGs. Since depolarization in the left and right ventricles are no longer simultaneous, the amplitude of individual waves is usually increased. And that's because simultaneous depolarizations tend to cancel each other out. You can see the effects here. In an ECG with BBB, there are prolonged, broad, late, and negative S waves, which are usually called depressions. Now, how can you tell the difference between a right or left bundle branch blockage on an ECG? Well, the main difference is that a right bundle branch block has a large, deep, and slurred terminal S wave, while a left bundle branch block has a positive, tall, monophasic, or one-phase R wave.
Now that we've gone over the heart's ventricular depolarization, let's explore how a bundle branch blockage would affect the conduction pathway. As the complication's name implies, the left or the right bundle branch of the conduction pathway are affected. When a bundle branch blockage occurs, the electrical impulses that are traveling down the heart's conduction pathway are inhibited at the branch at which the blockage has occurred. For that reason, the electrical impulses that are traveling down the functioning branch must reach the neighboring ventricle in addition to properly depolarizing its own. For that to happen, the impulses traveling down, let's say, the functioning left bundle branch, will have to slowly travel to the right ventricle as they don't have the efficient, functioning right bundle branch to do so. This lag in time is what creates the complications in the ventricular depolarization of a bundle branch block. Using what we just previously explored, we understand that in a right bundle branch blockage, the right fascicle is blocked. So the impulses have to return to the right ventricle after the left ventricle is conducted first. In a left bundle branch blockage, two fascicles are affected. The left anterior and the left posterior fascicle are blocked. So the right ventricle is conducted first, then the impulses travel back to depolarize the left. Partial blocks of the left bundle branch are also possible where only one of the two fascicles are inhibited. The presence of a bifascicular block, or a blockage of all the fascicles, would result in AV dissociation.
Bundle branch blockage is characterized by several complications. Regardless of the degree and type of bundle branch blockage, there are overlapping complications. As you can see on the ECG monitor, bradycardia and arrhythmias are evident. Another complication of bundle branch blockage is hypertension. Such complication puts the individual at risk for cardiac arrest. After myocardial infarction, the complications of bundle branch blockage become more sophisticated if it is developed. For example, if bundle branch blockage develops after myocardial infarction, the individual is more likely to face worsening complications mentioned before, including death. An individual may have a myocardial infarction, but not always develop BBB.
Morning.
Thank you for watching. We now hope you have a better understanding of bundle branch blockages that is necessary for our project. Now, let's get started.
Shut